Okay, so welcome everybody. I'm the research manager here at the FLF. Welcome to our very first webinar at the Follicular Lymphoma Foundation. We're delighted to see such a great turnout. I'm sure there'll be more people joining in the next few minutes, and we hope you find this really valuable. We recently launched our Your Support Hub on our website, and today we begin our new series of webinars. So do watch out for more coming in the next few months, where we hope to shed some light on topics that are of most interest to you, the FL community. So just a couple of housekeeping things from me, and then I'll pass over to our panelists. Today's webinar, I think you should also already be notified, is being recorded. And we plan to upload the final video onto our website, where only the speakers will be visible on that video. Thank you to all who submitted some brilliant questions at the registration, and we'll cover as many as we can today and save others for future webinars. You're very welcome to ask questions throughout today's session. Please use the Q&A area where possible, so that we don't want to miss them in the chat area. And finally, we'd love to connect a little bit more with everyone who has joined us live today. If you feel comfortable sharing, please do comment in the chat, whether you're an FL patient, a family member, a friend, or something else, and which country or region you are joining us from. So that's it for me. I'll pass over to you, Mitch.
Great, thank you. So yeah, I'm Mitchell Smith. I'm the Chief Medical Officer of the Follicular Lymphoma Foundation. It's really a pleasure to welcome everyone, all the attendees here today. We really appreciate your interest. This is the first of what will be a series of webinars, and so this will be fairly introductory level. We will be able to dive into other topics in the future. So for some of you who have been facing this disease for a long time and are experts of yourselves, hopefully you'll find something here, and as well as the people who are more recently diagnosed or under observation, etc. We could tell from the submitted questions ahead of time that there is a range of expertise. We are going to try to keep it accessible to the vast majority of the attendees as best we can. It is really my pleasure here to host two colleagues, experts in lymphoma. They are both expert clinicians as well as active in research. And we have a perspective from both the US and the UK. First, Dr. Jessica Okosin from St. Bartholomew's Hospital in London. So welcome, Jessica. And Dr. Brian Hill, who's the director of the lymphoma service at the Cleveland Clinic in Cleveland, Ohio, in the United States. So welcome to you. And so to start it off, I thought we would talk about a hypothetical case, a fairly common presentation, and then talk about what happens after you're diagnosed. So let's just take the case of a generally healthy man, say 65-year-old, who perhaps notes that his collars are a little bit tight when he buttons his shirt over a couple months, and feels around and feels an enlarged lymph node. He's pretty healthy, takes a statin for high cholesterol and maybe a baby aspirin, but generally active and working. And he goes to the doctor and finds a couple of small nodes, maybe a few centimeters or an inch or so, and gets a biopsy and some blood work. And I guess the question often is, how does this come about? I feel fine. What do I have? And what kind of biopsy do I need? And what's going to happen to me? So, let's, I think, well, we'll hold the poll for a second. Let me start actually with Brian. Dr. Hill maybe can discuss with us a little bit about, what you tell a patient with what kind of biopsy you need, and how you might proceed from this point.
Yeah, certainly. Thanks for the introduction, and thanks to the Follicular Lymphoma Foundation for the introduction and hosting the event. The case is very typical for what we see when we have patients who are newly diagnosed with follicular lymphoma. Oftentimes it's someone in their 60s. It would be sort of the average age. there are more males than females diagnosed with lymphoma in general and follicular lymphoma specifically. And the presentation is very typical in the sense that this is an individual who basically had what we call asymptomatic presentation. So no real symptoms other than this sort of enlarged lymph node that he was able to feel in his neck. Other times, sometimes, patient might present with a finding of an enlarged lymph node on an X-ray or a CAT scan or an MRI, CT scan, or a mammogram even. Some other test that's done for some other reason may note these enlarged lymph nodes. In the case of an abnormality like this, a tissue sampling is required to establish a diagnosis. Many times, particularly in the neck, because of all of the other structures, there's large blood vessels and other things coursing through the neck, of course. Patients are referred to an ear, nose, throat or otolaryngologist, head and neck surgeon, and sometimes a fine needle aspirate is obtained, which is oftentimes a bedside procedure done in the practicing ENT's office, in which the skin is numbed and a fine needle is passed into the lymph node, and a sampling may result in a sort of suspicious cell population or abnormalities. But really, to get a definitive diagnosis of this type of lymphoma or lymphoma in general, we really need a more substantial sampling. And so if it is suspicious on the fine needle aspirate, as we call it, then really a minimum something called a core needle biopsy, which is a larger bore needle, needs to be used to get an actual piece of the tissue with sufficient sampling to do proper testing, or in some cases, what's called an incisional or excisional biopsy, which would be done usually in the operating room, in which the whole lymph node is removed and then the stitches are done. So those are kind of the starting point for many patients with follicular lymphoma.
Great, thanks. That's very useful, because that's often a problem, is how do you go about making a diagnosis? Dr. Okosin, if someone comes back and the biopsy does come back follicular lymphoma, what are your next steps in terms of what, blood work, CAT scans, PET scans, bone marrows, et cetera? How do you approach the evaluation of such a patient?
Thanks for the question, Dr. Smith. I'm really pleased to be here. And as Dr. Hill has already sort of kickstarted the sort of investigational pathway. So once you've establish that, what the lymphoma is, the next stage is to try and do what we refer to as staging. So in other words, looking at the extent to which the lymphoma is involved. And that could involve a number of different tests. We typically do some routine blood tests and the blood work, mostly to assess to see whether there's any organ damage. So looking at things like the liver and kidney blood tests, for example, seeing if there's any signs that there are the bone marrow might be affected. And this can normally present with either the patient feeling, either breathless, indicating they may be anemia, so the blood counts might be a bit low, or some of the other cells within the bone marrow being affected. So we typically do the blood counts to just give us an idea of if the lymphoma is affecting organs or the bone marrow. Now, the next question you ask is then about, well, what about imaging, or whether they should be having bone marrows? There are a number of different modalities. So historically, we used to have CAT scans or CT scans. And these are scans that looks at the involvement of the lymphoma. Typically, these scans are done usually from the neck all the way down to the pelvis, and it gives us an idea of the stage of the follicular lymphoma. More recently, we have PET CT scans, which are more what are referred to as more functional imaging. So what they do is they look at the lymphomas and see how active they are. And follicular lymphoma is a particularly active type of lymphoma, so it's very easily picked up on a PET scan. In the UK, the recommendation is for a PET scan for staging for follicular lymphoma, but we're aware in many other countries, PET scans may not be available or routinely available, so CAT or CT scans are used. But these are the two main imaging modalities, a CT scan or a PET scan. Bone marrows are, I suppose, are becoming out of vogue. I mean, historically, a bone marrow is done where a needle is placed usually into the hips or the pelvic bone, and a sample of fluid and a little bit of the bone is taken out. And the reason that that's typically done is to try and understand whether the follicular lymphoma is affecting the bone marrow. And this can happen in about 50 to 60% of patients with follicular lymphoma. PET scans, because they're much more sensitive, the PET scans themselves can tell us if the bone marrow is involved. So I think bone marrows are starting to go out of vogue in terms of using it as a diagnostic tool, also because it's invasive, it can be painful for the patient. So in my practice, I don't tend to use a bone marrow scan, and I use a PET scan for staging.
Great, thanks. Yeah, that's covered a lot of the questions the patients ask about, the bone marrow and the PET scan. So that's very useful. So you sort of implied that, and we know that follicular lymphoma is a B-cell disorder, that the cells it's really a blood cancer, and it involves throughout the body. So it's very uncommon to have it localized. So then you have these patients who have stage 3 or 4 most commonly. And then you might say, you have advanced stage, but we're not going to do anything. And this really is very difficult for patients to accept and get used to. So Dr. Hill, when are patients in your office and you're sort of facing that situation, new diagnosis, no symptoms, how do you sort of get that idea across that maybe we should just watch this for a while?
Yeah, I agree that this is probably one of the most frequent concerns that we have when we discuss initial management of follicular lymphoma. Yes, it's true that in some cases we do recommend immediate treatment, and we can talk about what some of those indications are, but typically drenching night sweats, unintentional weight loss, severe fatigue, or pain or discomfort or organ compromise, organ dysfunction from an enlarged lymph node would be common indications for treatment. But probably the majority of patients don't have any of those symptoms at the time of their initial presentation. And so it's a little bit different from other cancers that we hear about so commonly. We hear about early staging or screening for breast cancer with mammography, early screening for colon cancer with colonoscopy, early screening for lung cancer to detect early stage tumors. And in those cases, what we call solid tumors, there is typically a surgery that's performed when it's an isolated tumor, what we call stage 1 disease. With follicular lymphoma and many other types of lymphoma, as you point out, most of the time we have lymphoma in multiple areas. So it's not something that's amenable to immediate surgical removal. And although the treatments we have are very effective, they do have side effects, and it's actually never been demonstrated that immediate treatment has an advantage over what we call deferred therapy. So it does become a little bit of a discussion, for, you have this diagnosis of a advanced stage lymphoma, follicular lymphoma, but we're not going to treat you right now because you don't need treatment. And the main reason is that, again, we don't have good conclusive evidence that there's an overall benefit to immediate treatment rather than deferred therapy. So it does take some discussion.
Okay, thanks. So before I move to Dr. Okason for next, I think it'd be a good time to open a poll we have and trying to get a sense of how many of you are under observation or watch and wait, goes under a number of terms, active surveillance. And if you have been treated, how long between your diagnosis and you did start treatment? So we just sort of get a sense, and it's usually a pretty broad range. So we'll give you a minute to enter that, and we appreciate your information. And let's see, I think I was going to talk over you, but maybe it looks like you're being pretty quick with these, and we're getting a lot of advances. So I think we have most of the, so yeah. I'm sorry, do you see the poll or?
Yeah, I can see it here.
Okay, all right.
you want me to read
does
the
the audience
results?
see the poll? Yeah. So maybe, I mean, it looks like there's a broad range as usual. Maybe I'll let Dr. Okosin comment on that, and then maybe follow that up with discussion a little bit about what things you look at when you tell the patient if you're, you know, they want to know, okay, I'm watching, but what can I expect? And do you give them any indication, oh, I'm a little more concerned you're going to progress early, or, wow, I'm really, you know, I think you're likely to do well. What sort of prognostic indices do you look at? But maybe first comment on the poll. Thanks.
Thanks very much. And just look at the poll, you know, this is a very broad range, what we would expect to see. I can see that some patients, participants here require treatment, you know, quite soon. So, you know, in the first sort of 6 months, and then others actually were watch and wait or active surveillance for over 2 years. So this is the distribution that we would expect to see, you know, we would expect to see. I think in terms of, you know, the kind of conversations that we have, obviously, Dr. Hill already alluded to some of this. I think it's explaining why this recommendation that essentially we want to try and save the treatment for when it's going to give the best impact. And when patients don't have any symptoms, or if the lymphoma is not infecting any of the organs, it is, you know, advisable or recommended that we don't need to rush to give any treatment. And generally, you know, the conversation that I have with patients, because of course, being diagnosed with a cancer and then being told, actually, we're not going to do anything about it, can create some sort of, you know, I think people can become quite anxious about it, can create an anxiety secondary to that. So what I commonly do is create a kind of a sort of a treatment plan with the patient. So I explain to them exactly why we're not treating straight away, what the prognosis or the outlook of follicular lymphoma is. So this is, we kind of think of it as, you know, almost like a chronic condition. So most patients are going to be living with their follicular lymphoma for many, many years. And so it's a kind of a long game in a way. And in terms of watch and wait, I explained to them that typically what that would involve is us as physicians keeping a very close eye on them. So that would usually involve regular clinic appointments, usually every 3 to 4 months. Usually when they attend that clinic, we'll check in to see whether they've had any symptoms, whether the symptoms have changed, have they noticed any new lumps that have increased in size. We'll also do some blood work as well to make sure that nothing has changed. So this is sort of the routine sort of schedule that we will take with a kind of a watch and wait approach. And this is typically what we will do. And I give them some guidance of what sort of things they could look out for in between clinic appointments. So if, for example, their symptoms change in any way, so if they developed what we call B symptoms, and that could be if they suddenly had fevers that could not be explained by an infection, for example, or if they found they're having night sweats, so sweating sort of more than they would normally do, particularly at night when they're drenching the sort of the sheets or the pajamas and so on, or if they've lost weight without a particular reason. So to be alerted to those particular sort of red flag symptoms. And, you know, the other thing that I think is quite important is to sort of direct them towards some support groups as well. I think that sometimes patients, you know, want to understand that they're not going through this journey on their own. And so sort of directing them towards support groups or other patients who are going through a kind of watch and wait strategy. So those are typically the kind of discussions I would have with patients as they're sort of starting on this sort of watch and wait journey. And then your second question was, you know, what are the triggers for, you know, for treatment? And I think most of it is very much patient directed. I think one is symptoms. So if the symptoms change in any way, if they're suddenly becoming more fatigued, or if they're getting these B symptoms, as I described, or if their lymph nodes suddenly increase very rapidly over a very short space of time. And if there are signs that these large lymph nodes are starting to impact or compress some of their organs, those would be sort of an indication to start thinking about treatment.
Great, thank you. So we have one question in the chat, in the Q&A, which fits very nicely with my segue here to Dr. Hill, which is, what's the role of a PET scan during watch and wait period? And it gets into the idea how often and what kind of scans you need. And it's a common question. You know, we all feel better if our scans look normal, but do you really need to get them? So I wonder if
Yeah, so in the US, a PET scan at the time of diagnosis would be considered fairly standard. The PET scan does give different information than a CT scan in the sense that it gives us details about how metabolically active each of the lymph nodes is. This can be given a number called an SUV, or standard uptake value, which shows, we call it glowing, or how bright, how much uptake that particular tissue has. After that initial PET scan, there does need to be typically some what we call surveillance to monitor for changes. This is typically done, in the kind of 3 to 6 months after the initial scan, depending on various factors. And it's difficult to say that you must do it at 3 months or you must do it at 6 months. And I think there is some variability in that. But I think in that time range, another scan is indicated typically. We, at least our practice, and I'm sure practices vary in the US as well as in the UK, but our typical practice after an initial PET scan would be to convert to what we call high resolution contrast enhanced diagnostic quality CT scans, because these actually give what we call finer detail of the anatomy of the lymph nodes and other structures in the body, and can really be, I think, more useful for monitoring for changes in any of those lymph nodes. It also has the advantage of being a little less expensive than a PET scan. And whatever system you're under in your country, there are cost constraints, whether it's by the National Health Service or by private insurance in the US. There are limits on the number of PET scans that we can do. And in this case, I'm actually very comfortable and prefer the CT scans that I described as a sort of surveillance. But I'm curious to hear from Dr. Kosin what the practice in the UK is.
Yeah, that's very interesting, Dr. Hill. So we don't tend to have surveillance scans during the watch and wait period. This is certainly in the UK, it's driven by the patient's symptomatology. So if their symptoms suddenly changed, over the course of their watch and wait period, or if suddenly their lymph nodes enlarge very rapidly, then we use those as triggers to initiate the next PET scan. In our practice, we, at least in my institution, we have access to PET scans that are sort of reimbursed. So we tend to use PET scans as surveillance if the patient's symptoms change.
So there is a comment in the chat, which I think is appropriate. What about the risks of repeated scans? If you're under watch and wait year after year, how often are you getting scans? What's the radiation exposure besides the financial cost? Are there risks to that? And do you try to balance that? And do you get them once a year, every 2 years, only if things change? What's sort of your approach to that?
Yeah, I think it's a very important question that many patients do wonder about. It is a hefty dose of radiation to have a full body CT scan or a PET scan. My sort of general approach is to decrease the frequency of the scans when I see stability of the lymphoma, so that maybe I'm doing them once a year, or I do have patients do them every 2 years, or in some cases after many years, we just stop doing them altogether. So we try to be thoughtful about it. And I agree that physical exam is obviously an important part of the surveillance. But there are obviously lymph nodes and structure things deeper in the body that can't be assessed by exam, that sometimes can present with enlarged lymph nodes that probably fulfill certain criteria to be treated.
Dr. Kosin, any comments on that? Or you tend not to follow them.
We don't really. I think we're guided, as Dr. Hill mentioned. I think if we have patients who don't have palpable lymph nodes, so if they have ones that are within the pelvis or within the abdomen, and those are the patients that I probably would watch a little bit more like a hawk, and they're the patients that are more likely that I will be scanning rather than not. But generally, exactly, I think that we should be mindful about the amount of radiation that they're getting. Each PET scan, is essentially the 3 to 5 years of background radiation. So if you can imagine, if these patients are having serial scans every 6 months or a year, it's quite a lot of radiation to be exposed to. So yeah, it's important considerations.
Okay, thanks. So I think we're going to switch gears now to what happens when a patient either presents requiring treatment meets those criteria, or in the case we presented earlier, say he's under observation for 3 years, starts to be fatigued, not able to get a full day of work in, you do some blood work, he's a little anemic, and you start to say, yeah, the disease is progressing, the lymph nodes are a little bit bigger. You restage him and the CAT scans show that. We're not going to talk much about the case where someone transforms to a fast growing, that we're going to save for later webinars. But, progressive disease, having symptoms, you start to think about, is this the time to start treatment? And then what treatments do you prescribe, or do you consider, or do you discuss with the patient how much interaction there is? So let's hear actually Dr. Okosan, you can start with that, and then after you, we'll have a poll on what people have gotten, and then we'll have Dr. Hill reply.
Yeah, thanks, Dr. Smith. I mean, as this classically happens, right? So patients have been watching waited for X number of years, and then their symptoms start to change over a period of time, and that could be increasing fatigue, B symptoms, or signs that their lymphoma might be, lymphoma might be growing. So we tend to, follow a set of recommendations that are triggers for us to start treatment. So one of them is something that was developed by the French group called the Guelph criteria. And essentially, this criteria gives us a recommendation of when we should consider starting treatment. And usually the triggers are, change in symptoms, signs that the lymphoma is becoming much more bulky. So either having very large lymph nodes over the size of 7 centimeters, or having lots of bulky lymph nodes in many places. So those are usually the triggers for us to start treatment. In terms of the treatment options that are available, and I know it'll be different in the US, and Dr. Hill will discuss that. But in the UK, I think if a patient with follicular lymphoma requires therapy, the treatment we'll be considering is a combination of chemotherapy with what we call immunotherapy. And these immunotherapy are typically what are called monoclonal antibodies directed to something called CD20, which is on the surface of these follicular lymphoma cells. In the UK, there are 2 options in terms of the monoclonal antibody. One is rituximab, or also called Rituxan, and the other is obinutuzumab, or I think it's called Gazyva in the US. So those options are available to us in the UK. This is typically combined with chemotherapy, and there are a number of different chemotherapy options. And again, those options, I think each of this is very individualized, because you have to take into account the patient in front of you, their age, their fitness, some of the other medical problems that they have when you consider which chemotherapy may be more suitable. In the UK, the second monoclonal antibody called obinutuzumab is actually not available to all patients. It's only recommended for patients that have one of these prognostic indices, something called the FLIPI score. So these is basically these are factors that we consider that gives us an idea of the risk behavior of the follicular lymphoma. So if the score of the patient is 2 out of 5 or more, then we have access to obinutuzumab. So typical options is essentially is chemotherapy combined with a monoclonal antibody.
Great, thank you. Yeah, I think that has been the standard now for some time. If we could open the other poll, I think it'd be interesting to see if you have had treatment. The bottom is if you haven't, but and we've left all of the anti-CD20s, rituximab, also known sometimes as Mabthera, or obinutuzumab or Gazyva, whether you got that alone with bendamustine, with a combination called CVP or CHOP, or perhaps you got Revlimid or lenalidomide as your initial treatment. So we'll let that go for a little bit. And as you're looking, so I think Dr. Okosan, so Revlimid is not available as a frontline treatment in the UK, is that? Yeah.
That's absolutely right, Dr. Smith. So despite the data is comparable to chemoimmunotherapy, but it's not available in the UK presently. Okay.
All right, so Dr. Hill, now you're seeing the poll, and it looks like it's a split between single agent anti-CD20, bendamustine, or CVP or CHOP based. And it looks like no one's got initial treatment with lenalidomide, although I can see in the chat that at least one person has had it, probably a subsequent line. So from what Dr. Okosan said, is that pretty much what you tell your patients or
Yeah.
doctors? Or...
Yeah. This looks like the breakdown that I would expect. What we call single agent treatment with rituximab or obinutuzumab. It is an option because it has very well tolerated, lower toxicity or side effects when compared to using one of those antibodies with more traditional chemotherapy agents. However, it tends to not get as deep or durable of a remission as when those agents are used with chemotherapy. And so then you're kind of left, for most, fit patients, bendamustine as the kind of chemotherapy partner for the antibody, or CHOP, or CBP is sort of a watered down version of CHOP. R-CHOP or bendamustine with Rituxan, sometimes called BR, were compared to head in two different clinical trials, one from the German indolent non-Hodgkin study group, and one from a US consortium. And in both of those randomized head-to-head trials, for most patients, bendamustine did improve the sort of what we call survival without progression of the disease, progression being growth of the lymphoma. And in both of those trials, bendamustine was shown to have better safety profile and fewer side effects. And so for that reason, it really has been, for the past, I would say 10 years or more, the standard option for most patients who need frontline treatment with follicular lymphoma.
Yeah, so I think in general, I think bendamustine rituximab is or with obinutuzumab probably the most common initial treatment. So let's what do you tell a patient to expect during bendamustine and rituximab? 6 months of treatment, 6 cycles. Sort of what can they expect during that treatment? Dr. Okas, you want to take that one? Or?
Yeah, of course. So I think rituximab bendamustine is probably the most common regimen that we use in our practice. So we discussed some of the obviously the benefits, as Dr. Hill has already alluded to. There's a very effective treatment. Most patients will have some sort of response, either a partial response or complete response in as high as 80-90% of patients. I talk about the treatment schedule. So this is typically a 6-month long treatment where the patients are, the schedule is typically, they'll have the rituximab on the first day with a dose of bendamustine, and to remind them that the bendamustine is actually for 2 days, because sometimes they forget about that. And so essentially it's 2 days in a 28-day cycle, and that's repeated for 6 cycles in total. And generally, in terms of the side effects that we talk about, the rituximab, as Dr. Hill already alluded to, is very well tolerated. The main things that we keep an eye out for is mostly allergic reactions or infusion-related reactions that they can get as they're receiving the antibody. And so typically the infusion is given at quite a slow rate to start off with, and the patient is monitored, and then the rate is increased or ramped up as long as they're tolerating it well. So I think generally rituximab very well tolerated. Bendamustine is a chemotherapy, although actually it's very well tolerated. The patients are always surprised when I say, actually, you're not going to lose your hair with bendamustine. So it's one that you don't tend to, unlike other chemotherapy regimes, you don't tend to lose your hair with that. As it is chemotherapy, there is risk, of course, in terms of infection. The blood count can go down, but again, not as severe as some of the combined chemotherapy. So those are the things we tend to look out for. It's and we warn them about infections, and for them to be quite militant about checking their temperatures, making sure if they have fevers that they should be contacting our unit. So allergies with rituximab, and then chemotherapy is mostly infection-related side effects.
Great, thanks. So I know in the I don't want to a couple of topics I want to get to, and I see in the constraints of time. So at the end of your treatment, your 6 months, say, of BR, you're feeling better, you've recovered from the side effects, and your CAT scan or your PET scan shows that you're in remission. The next major question is, what about maintenance? Is there any reason to continue treatment, particularly with rituximab or Gazyva or obinutuzumab? So, Dr. Hill, what do you tell a patient about? Are you done and we're going to watch and wait, or do you give maintenance? What do you tell them about that?
Yeah, we wish we could say that we've cured the cancer at that point, but we know from our decades of experience that follicular lymphoma tends to recur with, if given enough time. And so there's always been interest in finding a way of sort of kicking the can down the road, so to speak, or avoiding the recurrence, prolonging the remission by a non-toxic, well-tolerated treatment. And so there have been many studies of using rituximab by itself as a single agent in different schedules. There's been some studies where it gives 4 weekly doses every 6 months, but a more common approach is 1 dose every 2 months for 2 years. And when this is applied after chemotherapy, such as R-CHOP, the duration of the remission tends to be much better than if you don't do it. Now, the caveat is, if you look at the actual how long people live, whether you do this or not, it's actually the same. So historically, over the last, I think, 5 to 10 years, there's been many debates in the oncology field about the merits of maintenance treatment. It does suppress the immune system a little bit and makes people a little more susceptible to particularly sinus or upper respiratory infections. So it's not a completely risk-free treatment. There are those who think it's a great option because it buys you many more years of remission with only 2 years of maintenance. But then there are those who say, well, let's just leave the patient alone, let them recover from their treatment, and if their lymphoma comes back, then we can use Rituxan at that time. And so I would say we used to use a little bit more Rituxan maintenance up until the COVID-19 pandemic. And starting in 2020, it became more and more obvious that rituximab, as it depletes our normal B cells, in addition to targeting the cancerous B cells, it is actually a very high-risk situation for developing severe COVID. So I would say our practice, and probably much of the U.S. Has backed off on maintenance treatment for this particular type of lymphoma, follicular lymphoma, because of the risk of COVID.
Great. Dr. Akosin, is similar? Was rituximab maintenance an option in the UK? And if so, has it changed with COVID?
Yeah, no, it's a great question. And as Dr. Hill mentioned, there isn't a consensus at the moment on how best we should do this. In the UK, because the question is, addressing this is quite challenging, we actually have a phase 3 trial open in the UK to try and address that question. Do patients, if you achieve, a very good response after the first line of chemoimmunotherapy, do they need to still have rituximab maintenance? So that's the question that we hope will get addressed in this clinical trial. And so generally, I recommend the clinical trial to my patients. Outside of a clinical trial, I think my use of rituximab is certainly less, I think COVID has taught us to be cautious with rituximab, particularly because of the suppression, the immune suppression, increase, risk of severe COVID. So generally, I think if patients achieve a complete remission, I try not to give them maintenance outside of a clinical trial. If they've got a partial response, that means that most of the lymphoma hasn't gone away, then I'd be probably a bit more inclined to consider maintenance in that situation.
We have a couple minutes left. There's a couple of questions in the Q&A that I just thought you'd address. So we did have in the poll rituximab as a single agent, and one of the questions is, well, I only got it for 4 sessions. Is that unusual, asymptomatic stage 3 disease? So can you just maybe, Dr. Hill, comment quickly on, we get rituximab, we heard about it in BR, you get it once every 4 weeks, how you use it as a single agent and how that differs?
Yeah, so I would say it depends on why it was given. If you have what's called low tumor burden by those GELF criteria that were mentioned, and don't have what we would say would be a strong treatment indication, maybe some mild fatigue or maybe some cosmetic effects of some small lymph nodes, then using single agent rituximab is reasonable. And there was a large study actually led through the UK consortium that compared 4 doses of Rituxan to watch and wait for these low tumor burden follicular lymphoma patients. And there was a third arm that compared 4 doses of Rituxan with maintenance treatment. And actually, the 4 doses does do quite a bit more than nothing. It doesn't quite do as much as 4 doses followed by maintenance. So I don't think there's a right answer here, and it really does boil down to why the treatment was given, what the response to the treatment was, and what the patient and the oncologist think the goals of the treatment are.
I think that's the key, because there's additional questions about, yeah, I've had it, I've shrunk in half. Is that good enough? What do I wait? And again, so it really has to be individualized with your why you're getting it and with your oncologist. There's a quick question about ports. I don't know, Dr. Okeson, do you use ports very much?
It's an interesting question. So there's a lot of variability even in the UK. I know that there are some centers, for example, Oxford uses ports quite a lot. We don't actually. We find that actually for these chemotherapy that it can be delivered by just a peripheral cannula, and because it's every 21 days or 28 days, I think most of the patients' veins adequately recover to be able to have one of these cannulas. So we don't tend to use it. I have had some patients who are either needle phobic or just have veins that are just not conducive to repeated cannulation. So in those cases, we will usually consider a PICC line, which is a peripheral inserted sort of cannula, rather than a port, which sort of sits sort of in the chest.
Thanks. So I know we're coming close, and there's lots of questions. We'd love to answer them all. We mentioned we haven't even touched on all the exciting new treatments for the second line and later that may be moving up to front line. But I really want to thank both Dr. Okeson and Dr. Hill. Really clear exposition of all these issues. Would have no one right answer. Almost any of these questions there is no one right answer. And that's what makes follicular lymphoma so interesting, but also difficult. It's easier if the doctor can say, this is the data, this is what you're going to get. But there's always this sort of sense of, well, there's a few different ways to go. So with that, I think we're just at time. I don't know if there's any way that I can answer some of these questions after. I'll find out. Can't prescribe individual, but we could comment on some of them. We tried to cover most of them. I'm seeing one that says, someone says, oh, we should have an hour and a half. Yeah, so we will have more of them, and I understand, and we hope that these will be an ongoing series. We would like your comments, though, like that. Maybe we should do that. Maybe we can have a couple of different things. So anything, this is our first one, and we are very anxious to have feedback. What was good, what was not so good, what we could do better, and what would you like to see as future topics?
And just to expand on that, just to let you know, there is a big specialist lymphoma symposium conference that we are attending in June, and we really want to share our insights and learnings from that. So watch out for something coming in July. But yeah, equally other updates as well on your support hub. There will be a little short feedback form that will appear, I think, at the end of the webinar, so we'd love to hear your impressions through that as well. And that's all I have.
Okay, again, thank you, Dr. Okeson and Dr. Hill. Thank you all attendees for being here. We appreciate your input, and please visit our website. There's more information there that might help you as well. Thank you.
Thank you. Take care.
Thank you.
Thank you.